So without further ado, I'd like to introduce our first speaker, Dr. Fatema Ghasia. She's the Director of Vision Neuroscience and Ocular Motility at the Kola Institute, and she will be talking about minuscule fixation eye movements play a major role in amblyopia. Fatema.
Thank you. Sorry, I thought I had it. Okay. All right. Good afternoon, everyone. I'd like to thank the organizers for inviting me to present. Today, my talk will be on fixation eye movement abnormalities in amblyopia. So visual system has a built-in paradox. We must fixate our gaze to inspect minute details of the world, yet if we fixate perfectly, the entire world would fade from view due to neural adaptation. Let's take an example. If you were to fixate steadily on the black cross long enough, after several seconds, the purple circles will begin to disappear. Movement of the eyes will bring the purple circles back to perception. This phenomena is called Troxler fading. Thus, during attempted fixation, when the highest visual acuity is achieved, our eyes are not completely motionless, but instead we see miniature involuntary fixation eye movements, or FEMs. Here's a video from a control subject doing a fixation task. The pink and the green represent the right and the left eye. Notice that our eyes are not perfectly still and there are small eye movements that occur. A number of labs have shown that these fixational eye movements, or FEMs, are important in maintaining visibility during fixation. Now, physiologic FEMs, they produce motion that cause variability in eye position that is confined mainly within the fovea, and this is referred to as stable fixation. Here's a scatter plot of horizontal and vertical eye positions of right and left eye from a control subject obtained during visual fixation. Notice that the eye positions, they are tightly packed together with less variability. Fixation stability is usually quantified using a measure called bivariate contour ellipse area, or BCEA. So the smaller the value of the BCEA, the more stable is the fixation. A more comprehensive approach to evaluating fixation is to look at the actual eye positions that are obtained over time, similar to EKG traces. So these are horizontal and vertical eye position traces of right and left eye from a control. Notice that there are these fast eye movements called fixational saccades or microsaccades, as indicated by these black arrows, and they alternate with intersaccadic drifts, as indicated by red arrows. So in normal subjects, the microsaccades, they are binocular, they are small amplitude, less than 1 degree, and they are conjugate. So the amplitude and direction are same between the two eyes, and they occur at a frequency of 1 to 2 per second. Now, fixation instability has been reported in amblyopic patients. As we know, amblyopia is a neurodevelopmental disorder secondary to abnormal visual experience during early childhood, and it can arise from anisometropia, strabismus, deprivation, or mixed mechanisms and affect 2 to 4% of our population. These are eye position scatter plots obtained from a patient who had anisometropic amblyopia, and this is from a patient who had strabismic amblyopia. Red trace here is the amblyopic eye, blue trace here is the amblyopic eye. And notice that the amblyopic eye has more fixation instability compared to the fellow eye. Another way to evaluate fixation instability is to look at the instability in depth, and this is measured with vergence BCA, where you take the difference in eye position between the two eyes, and as you would expect, strabismic amblyopes have greater vergence instability as indicated by these pink traces. Now, to characterize the fixation instability seen in amblyopia patients, we measured FEMs under both eye viewing, good eye viewing, and amblyopic eye viewing conditions from 115 subjects. We use a remote camera, so the camera is on the desk, so there's nothing touching the face, which makes it easier to obtain recordings in children. The camera has very good sampling rate and spatial resolution, and the setup time is less than 2 minutes. Here's the distribution of our cohort. We had patients with anisometropic amblyopes, strabismic, and mixed, and then we had some controls, and we have all different severities of amblyopia that were well represented. So we evaluated their fixation eye movements and divided them into 3 groups. This is an example of a patient who had severe amblyopia and did not have nystagmus. Magenta is the amblyopic eye. Notice that there was an increase in the drift of the amblyopic eye. Again, in addition to increased drift, they have increase in the amplitude of the amblyopic eye. These are the scatter plots, and you see that the fixation is unstable in amblyopic and fellow eye, particularly during amblyopic eye viewing condition. Here's an example of patient who had FMN. So fusion maldevelopment nystagmus or latent nystagmus develops when there is disruption of binocularity in early infancy. So you can see there is nystagmus as indicated by these jerks or beats in the eye movements. And when you look at the actual eye position traces, the nystagmus, the seesaw oscillations are seen during both eye viewing, but they are more pronounced during fellow and amblyopic eye, particularly during amblyopic eye viewing condition. Another key feature of FMN is the slow phase, which is the pathologic phase of the nystagmus. It's always directed towards the nose. So when the fellow eye is viewing compared to the amblyopic eye viewing, there's a reversal in the direction of the nystagmus, and which is the hallmark of FMN. Now we see that patients with amblyopia can have nystagmus who do not meet the criteria of FMN. And here's an example of one such patient. The nystagmus is most evident during amblyopic eye viewing condition, as indicated by these seesaw traces here. And the key feature here is that there is no direction reversal of the nystagmus between fellow and amblyopic eye viewing condition. So when we looked at the distribution of these FEM characteristics per the type of amblyopia, what we found is that anisometropes were less likely to have nystagmus, strabismus patients were more likely to have nystagmus with and without FMN, and mixed amblyopes had pretty equal distribution of FEM different waveforms. So why is it important to look at these FEMs? So we wanted to see whether these FEM abnormalities are linked to treatment outcomes. So patching therapy is most commonly used is prescribed for amblyopia, but we know that despite good compliance, 40% of patients have recurrent or residual amblyopia. Some predictors are severity of amblyopia and older age at time of diagnosis. Based on our studies and others, we know that FMN gets worse when one eye is viewing. And as you know, during patching therapy, we patch the good eye and the amblyopic eye is viewing. So the question we asked is, does patching therapy, the outcomes vary if you had presence of FMN? We hypothesized that patients without nystagmus would respond quicker and would have more improvement over a short period of time compared to those without FMN. So we recruited 53 amblyopia patients and who had eye movement recordings in at least 12 months of follow-up after the patching therapy was started. And we looked at 3 outcomes. We looked at patching duration, the extent of visual acuity improvement, and stereopsis improvement. And clinicians generally tend to think of amblyopia per their type of amblyopia. So interestingly, we did not see any substantial difference in patching duration, maybe less improvement in visual acuity in patients with mixed amblyopia, and then better stereopsis in patients with anisometropic amblyopia. However, when we categorize the same cohort using FEM waveform characteristics, we see that patients with FMN, they require much longer durations of treatment than those without nystagmus. The acuity improvement is less, although this did not reach statistical significance. But most importantly, despite treatment, their stereopsis recovery was poor, with majority of patients having poor or absent stereopsis. So since patching therapy has some drawbacks, there is a lot of interest in devising newer amblyopia treatments, and one commonly investigated one is the dichoptic treatment, where different stimuli are presented to each eye, low contrast stimuli are presented to fellow eye, and full contrast to the amblyopic eye, and the idea is to overcome suppression and allow for binocular combination. Now, large-scale pediatric dichoptic treatment studies have produced mixed results in terms of effectiveness to treatment. So we asked, can FEM abnormalities explain the variable response during dichoptic viewing? And so we measured FEMs in 4 trials where the amblyopic eye contrast was the same at 100% and fellow eye contrast was lowered. And I will go through 3 patient examples in the interest of time. This is a patient who had strabismus.
Dr. Ghasia, sorry, but you have very little time left. So
okay.
You've already used some 8 minutes. Yeah.
Okay, so real quick, basically what I wanted to demonstrate here is that as you lower the fellow eye contrast, the patients get the strabismus angle worsens, but in this patient, the amblyopic eye is fixing. So you know that when you present the dichoptic stimulus, this patient is likely going to respond to treatment. As opposed to that patient, this one here, the strabismus angle continues to get worse as the fellow eye contrast is reduced. And so this patient is less likely to respond to dichoptic treatment. We also find that the instability gets worse at lower fellow eye contrast. And this is just a summary slide showing that BCEA and Virgin's BCEA indicates that the fixation instability is worse at lower fellow eye contrast. And these factors collectively can explain the variable treatment response. So I think I'll conclude at this point. I thank you all for your attention, and I'll take any questions.